Evening to all the people present here. Thank you very much for joining, and this will be one of the first classes which we have planned for the MCQ based preparation for critical care medicine for the upcoming sessions. This will basically be a session of series of classes which we are planning to run from this month, and as we progress, we'll increase the frequency of the classes, and that is going to slowly pick up and we'll finish off by the end of by mid March or early March is what we planned, right? Because we are targeting the INISS session and the NEET SS session of March 3rd, like March 30, 31, the NEET SS session that's there, and the April session of INISS is what we are targeting. So I believe since there's a recent change in pattern of INISS, where the questions are going to be mostly from core critical care, I think this combined preparation will actually be kind of useful. So we thought we'll go ahead and do this series of classes. The first 2 or 3 classes will be a kind of trial classes, which will help us to get in touch with you and see what your expectations are and how you want the things to go as we progress. And as we move ahead, we'll have much serious and much frequent classes as we move ahead. All right. So we'll move forward with these set of classes. So the first class for now will be ARDS, which is we'll be having an MCQ based discussion for ARDS, and we'll be probably for the next 1 hour we'll be discussing about a series of MCQs that maybe not exactly like for like might not appear in your exams, but these are topics under ARDS that are usually tested, and probably these are the things that are worth studying. Am I audible to all of you?
Yes, sir.
Yeah, thank you. So my screen is visible, right?
Yes, sir. The screen is visible.
So the first of all, I start with a disclaimer saying that in today's class, we learn to solve MCQs in critical care from ARDS. We are not going to learn all of ARDS critical care today, right? See, ARDS by itself is a topic that will take a lifetime to learn and understand. So this is not something that is like a bread and butter of critical care, but yet there's always something that is not understood. There's always something under study, and there's always something that you might not always understand completely as far as critical care is concerned. As far as ARDS and critical care is concerned. So this is quite a complex topic. What we'll do in the next 1 hour is we'll try to break it down into simpler MCQs and see if we can solve those at the end of the class. So this is your first question. What we'll do is I'll have a series of questions. You can type in your answers in the chat box so that I know where we all stand right now, and based on that we'll go with the right answers and the explanation thereafter. So going forward, it's a 48-year-old male that we have with severe necrotizing fasciitis of the right lower limb, presenting with sudden onset breathlessness since 3 days. He is intubated for worsening distress, and his PaO2 is 78 millimeters of mercury on an FiO2 of 0.5. His chest X-ray shows bilateral opacities with no effusions and collapse. His echocardiography shows normal LV systolic function and filling pressures. So now we need to identify the correct statement regarding this patient. This patient has severe ARDS. B. The bilateral opacities are due to hydrostatic edema. Then the patient does not satisfy the Berlin definition of ARDS, and necrotizing fasciitis can cause ARDS in this patient. So which of the following is the correct statement? All right. Do you have answers? Can see one. I'll be very clear here. We are not going to mind anyone being wrong or right here. Very simple reason. We are here to learn. I am here to learn with you to teach, and you are here to learn with me. So I don't think anybody is going to judge you based on what is happening. Your answers you're going to give here. So the more you answer, I think you get better in solving MCQs. That's how MCQs work. So I think you'll have to answer it better. Okay. So most of you say one. That is A. That is the patient has severe ARDS, while one person says there is a bilateral opacity due to hydrostatic edema. All right. So we'll move forward and see what the answer is, and then I'll explain to you what the right answer is. The right answer is necrotizing fasciitis can cause ARDS in this patient. So what is the idea here? We'll go option by option. The first option, that is the patient has severe ARDS. I'll come to it in a minute when we talk about the definition of ARDS. The idea here is to tell you that ARDS is not just the pathology of the lung, right? Not only the pathologies of the lung that cause ARDS. ARDS is a heterogeneous disease of the lung, but that can be caused by any systemic inflammation, right? Any systemic inflammation anywhere in the body can secondarily cause an injury in the lung and can cause ARDS. So necrotizing fasciitis in this patient can cause ARDS. That's the right answer. Why are the other answers wrong? In a minute, I'll tell you. So look at the diagnostic criteria for ARDS. This is called the Berlin definition, right? This definition that we have right here called the Berlin definition of ARDS, which is time tested and has existed with us for a very long time right now. It has 4 criteria: severity of oxygenation defect, onset, chest radiograph, and absence of left atrial hypertension. Thus, you need to have no other apparent causes for for the pulmonary edema that you have. See, ARDS, you know, is a non-cardiogenic pulmonary edema, right? So there should not be any cardiogenic component to it. That's exactly why you do echocardiography and rule out that there is an increased pressure. That is what we call the hydrostatic edema. If you have failure, you have a lot of pressure, which is going to cause increased hydrostatic pressures and cause hydrostatic edema. That's exactly why we need to rule out hydrostatic edema by doing an echocardiography. So that's why in this patient, when we spoke about, we said the patient, bilateral opacities are due to hydrostatic edema might be wrong, because this patient has a normal echocardiography as given in the question, right? The question says the patient has a normal echocardiography, which effectively means the hydrostatic edema is not the only reason why this patient has he might have a underlying heart failure, but as far as what we know from echocardiography, his systolic function is normal, filling pressures are normal, so more likely that he does not have a high systemic filling pressure or high hydrostatic edema. It's not the hydrostatic edema is not due to hydrostatic pressures. Now go to the chest radiograph. He has bilateral opacities that are consistent with pulmonary edema, but there are no effusions, no lobar or lung collapse or nodules. This is your primary. So this is what you have when you have a primary lung condition. When you have a pneumonia, just a consolidation causing low oxygenation and occurring within 1 week is not ARDS. The patient can have one isolated in one lobe. The patient can have a consolidation. If that consolidation causes hypoxia and occurs within 1 week of clinical insult, would I call it ARDS? Absolutely not. So you need to have bilateral disease. One, the bilateral disease has to look like pulmonary edema. But this pulmonary edema and this bilateral opacity should not be explained by effusions, lung collapse, or nodules. Neither should it be explained by any cardiac etiology. This is how you differentiate ARDS and cardiogenic pulmonary edema. Next. So the onset, the term itself is acute respiratory distress. So the term is acute. When you say acute, I definitely have to have it within 1 week of clinical insult or worsening history. So the history has to be within 1 week. And most important is the oxygenation, because ARDS is a disease of the lung. Ultimately, it's going to cause oxygenation defects, and the oxygenation defect is classified into mild, moderate, and severe based on the PaO2 of the patient and the FiO2 that you are giving to the patient. So the PF ratio is between 200 to 300, it's called mild. Between 100 to 200 is called moderate, and less than 100 is called severe. Now going back to the question, look at the PF ratio here. The PaO2 is 78. FiO2 is 0.5, that is 50%. So if I divide it and multiply it by 100, it's going to be 156. So if it is 156, according to this definition, it's going to be moderate ARDS and not severe ARDS. That's why your option A is wrong. Option A is wrong because this patient has moderate ARDS and not severe ARDS with a PF ratio of 156. The bilateral opacities are not due to hydrostatic edema. It looks because of inflammation, and that's not hydrostatic edema. The patient's echocardiography is normal, and the patient does satisfy the Berlin definition of ARDS. The stage of 3 days, there is an insult. There is no echocardiographic findings to underline a cardiac etiology, and the PF ratios are low. And more importantly, there is bilateral interstitial infiltrates on chest X-ray with no effusions and collapse. So the patient does satisfy the Berlin definition of ARDS. Now, am I clear with this? So if we are clear with this, I'll teach you one more concept in this. ARDS is usually classified into primary and secondary ARDS. So primary ARDS and secondary. Primary ARDS, the ARDS caused by disease of the lung per se. If a disease is affecting the lung, say, for example, a pneumonia. For pneumonia progresses to cause significant inflammation of both the lungs and causes ARDS, that is primary ARDS. Any other insult apart from the lung insult, like a trauma, burns, pancreatitis, and as in this case, necrotic infection or sepsis anywhere in the body, all of this can cause a secondary ARDS. Usually, primary ARDS carries a worse prognosis when compared to secondary ARDS. Then the treatment for secondary ARDS primarily is to treat the underlying cause apart from treating the ARDS also. We'll move forward. Now here, a 45-year-old male presents with acute onset respiratory failure and worsening hypoxemia over the past 24 hours. His chest X-ray shows bilateral opacities not fully explained by effusions, atelectasis, or nodules. The patient is currently not intubated and receiving high-flow nasal oxygen, which is more common nowadays after COVID, at 40 liters per minute. His pulse oximetry shows an SpO2 of 92% and an FiO2 of 0.5. Which of the following criteria confirms the diagnosis of ARDS in this patient? Bilateral chest opacities and PF ratio less than or equal to 200, and SpO2 by FiO2 ratio of less than or equal to 315, and bilateral opacity with no alternative explanation for respiratory failure, requirement of invasive mechanical ventilation and bilateral opacity on chest imaging, PF ratio of less than 100 with a positive index prediction of at least 10 centimeters of water. So which of the following criteria confirm the diagnosis of ARDS in this patient? Look at it very closely. Okay, so I'll move forward. Somebody says B. Yeah, so we'll see what is it. See, all along the age-old teaching about ARDS has been only in intubated patients, right? Whatever Berlin definition that we speak about and all the other definitions of ARDS that we speak about, they are all speaking only about intubated patients. We have never had definitions about patients who have not been intubated but are still in ARDS. How do we differentiate these patients? Patients who have intubated. Imagine you don't have an ABG, right? In low resource settings where you do not have an ABG, will I not be able to diagnose ARDS based on the previous criteria? When we look at the previous criteria, you look at this criteria, you look at very closely, look at the bottom of the table. It clearly says it has to be assessed on at least 5 centimeters of water of positive end expiratory pressure, right? So you need to have some PEEP. What if I am giving only face mask oxygen to the patient or HFNC to the patient where I'm not able to measure the PEEP? I might not be able to give patient any PEEP. Would that mean the patient is still not in ARDS, or would I not be able to define ARDS in these patients? So that is why what happened recently in 2023, we had what is called as a modified global definition of ARDS. This is a potential question in any of the upcoming critical care exams because this is something that happened in 2023 and this has actually changed the way we look at ARDS. So this is a very potential question or a very potential concept. The answer you guys said appropriately is B. It's called the recent trend is to look at the SF ratio. In patients HFNC, you look at the SF ratio and you do not look at the PF ratios. Also, you don't have to worry about the PEEP in these patients as long as the flow on the HFNO is more than 30 liters per minute. If you're going to look at ARDS or define ARDS in a patient with ARDS, with on HFNC, you need to make sure the flow is more than 30, the requirement of flow is more than 30 liters per minute. And then look at the SF ratio or the PF ratios and go ahead with diagnosing ARDS in these patients. The same thing applies for NIB. So we'll come back, we'll assess the global definition of ARDS in a minute after finishing the next question. Look closely. This question, a 55-year-old male admitted to a rural hospital with acute onset dyspnea and hypoxemia. The hospital lacks advanced blood gas analysis or mechanical ventilators. He is on supplemental oxygen by a simple face mask. The previous patient was on HFNC. But this patient is on a simple face mask and his saturation is measured as 90% on an FiO2 of 0.5. Chest X-ray shows bilateral opacities that cannot be explained by efficient atelectasis or normal. How do you confirm the diagnosis of ARDS in this patient? You say a PF ratio of less than or equal to 300 with a minimum PEEP of 5, SF ratio of less than or equal to 315 irrespective of PEEP or minimum oxygen flow rate, SpO2 of greater than or equal to 97% with bilateral opacities on imaging. Requirement for non-invasive ventilation HFNO in this patient would mean ARDS. So how do we define ARDS in this patient? So once you answer this, we'll combine the answers to both the questions and we'll look at the new definition of ARDS. Yeah, so pretty simple. I just told you the answer previously. It is B. So why do I say this? Now look closely. Look at this definition of the diagnostic criteria for ARDS. This is just the image. I'll show you in detail. So this is what the new global definition of ARDS is all about. Look at 4 different criteria. The same thing, but in a different way right now. You look at the risk factors and origin of edema. We spoke about hydrostatic edema there. Now we'll have to look closely and look at any presence of any risk factors and origin of edema. Risk factors I already told you could be pneumonia, could be non-pulmonary infection or sepsis, trauma, transfusion, aspiration or shock. Any of this can cause systemic inflammation, and that systemic inflammation can cause in the lung an ARDS. So pulmonary edema is not exclusively or primarily attributable to cardiogenic etiology, which I told you in the previous question. Do an echocardiogram, rule out cardiac failure. The pulmonary edema should not be because of a cardiac etiology. Once that is done, you can always then look at the timing, history. The history is less than 1 week, it's acute, right? That is done. Chest imaging, again, same thing that we applied to the Berlin definition. There should be bilateral disease. There should be bilateral B lines or bilateral consolidation. And look very closely. There is also an ultrasound definition in this particular definition. The previous definition had only chest X-ray, but look closely chest imaging. It says bilateral opacities on chest radiography and computed tomography or bilateral B lines or consultations on ultrasound. So ultrasound has been incorporated into the definition of ARDS recently. That's a very important point to be noted as far as the new definition is concerned. Now move ahead. The criteria of oxygenation is what differs between very drastically between the previous definition and this definition. It is divided into three different criteria: non-intubated patients, intubated patients with ARDS, and modified definition for resource-limited settings, which we saw in the last question. We'll go one by one. Look at the non-intubated ARDS patients. You look at the PF ratio of less than or equal to 300. The classification of 300, 200 to 300, 100 to 200, and less than 100 remains the same as far as non-intubated patients are concerned, as far as PF ratio is present. Look at it closely. If there's an SF ratio of less than 315, if I do not have a PaO2, if I'm not able to do an APG, the next thing I'll probably look at is the saturation probe. I have a pulse oximeter. I attach the pulse oximeter and I say, okay, this patient, I will look at the SF ratio. I look at the SpO2 divided by the FiO2, provided my SpO2 is less than 97%. If my SpO2 is less than 97% and my SF ratio is less than 315 on high flow nasal oxygen with more than 30, or if the patient is on NIV or CPAP, the PEEP should at least be more than 5, right? So that is the criteria here. Your PF ratio has to be less than 300. Your SF ratio should be less than 315 if SpO2 is less than 97, provided HFNO. See, the non-intubated guys are going to be either on NIV or HFNC, right? So if it's an NIV, you take it up as you look at if a PEEP requirement is more than 5. If you look at HFNC, you see the flow and say if the flow requirement is more than 30. Based on this, you define ARDS and patients with non-intubated criteria. In intubated ARDS, you look at it almost remains the same, but here they have added the SF ratio for you. The PF ratio definition of more 200 to 300, 100 to 200, less than 100 remains the same, but the addition is to add the SF ratio. The SF ratio criteria here is 315 is the magical number. You remember 315? So 235 to 315, 148 to 235, and less than 148. Just remember these numbers because they might be asked. 315 is a magical number. 235 to 315, 148 to 235, and less than 148, mild, moderate, and severe, respectively. Provided all the SpO2 is less than 97% here. When you look at the SF ratio. And provide, see, I have HFNC, I have NIV if I'm in a tertiary care center, if I'm in a high resource setting. But in the low resource setting, as in most of places where you're going to go and work are going to be, I might not have an ABG machine. I might not have HFNC. I might not have NIV. All I'll have is a simple face mask. So what do I do in these patients? I'll always have to look at the SF ratio. Irrespective of the PEEP, irrespective of the flow rate, if the SF ratio is less than 315 and SpO2 is less than 97, I would diagnose that patient with ARDS, hands down, right? So that is what it says. If you're able to look very closely at this, I'll share this article with you guys. To calculate the FiO2 based on the flow, they have given a formula. If you look very closely, right? So it is given as ambient FiO2 that is equal to 0.21 plus 0.03 into your O2 flow rate. That is the formula is given. If you look closely, it is given in the fourth row, just below the tabular column. I'll share this article with you. You guys can go and read it. Maybe not fully, just the newer definition, and that can be enough. Your FiO2 definition is the calculated FiO2. If for someone in face mask, it's going to be FiO2 0.21 plus 0.03 into your O2 flow rate. That's going to give your FiO2 for that particular patient. That's it. That's all I want you to remember from this particular table. This is a new definition of ARDS. I hope this is clear. The first two questions, the first three questions have given you an idea about what is ARDS defined as based on the Berlin definition and why the Berlin definition has been changed. Because now we see more patients on NIV, we see more patients on HFNC, we see more patients in resource limited settings, and we also use a lot of lung ultrasound in the ICUs. So we'll have to incorporate all this, and the guys have done, the people have done a very excellent job by giving us this new definition of ARDS, which makes life very easy. Right? We'll move on to the next question. Any doubts? Should I stop here for a minute? Okay, I'll assume that your things are clear. We'll move on. Which of the following is the most common condition causing ARDS secondary to an indirect lung injury? A. Sepsis. B. Acute pancreatitis. C. Aspiration of gastric contents or aspiration pneumonia. D. Pneumonia. Pretty straightforward question. I just told you what is direct and indirect or primary and secondary ARDS. So based on common sense and based on what I told you so far, what do you think would be the right answer? Yeah, there are a lot of A's here. All of you saying sepsis. That's the right answer. Very straightforward. Just look at the tabular column for your understanding. Direct lung injuries could be pneumonia, aspiration, like injury to the lung per se, causing pulmonary contusion, drowning, and all that. Indirect is any other injury to the body, sepsis, burns, trauma anywhere else in the body apart from the lung. Transfusions can cause TRALA, which is an indirect lung injury. A drug overdose, pancreatitis, and post CPB. If you are someone working in the cardiac theater, you know that post CPB patients can develop indirect lung injury because of extensive SIR, that is systemic inflammation. All right. Now, a bit of pathology. I want you to identify the incorrect statement regarding the proliferative phase of ARDS. So it usually lasts from day 7 to day 21. It's characterized by lymphocyte predominant pulmonary infiltrates. Type 2 pneumocytes proliferate among alveolar basement membranes, and patients are liberated from mechanical ventilation and are symptom free. What do you think is the answer here? Okay. So answer somebody says is D. Okay, I'll move forward. The answer is D. Yeah. So you look at the proliferative ARDS basically has three phases, which I'll move forward. And as I move forward, I'll tell you about the three phases: the proliferative phase, the exudative phase, and the fibrotic phase. Here we are looking at the proliferative phase, which is usually from day 7 to 21. It's after the first week of insult. And there's a lot of lymphocyte proliferation, and that causes the pulmonary infiltrates at this particular point of time. And the type 2 pneumocytes that you know, they along the basement membrane, they proliferate a lot, forming what you call the hyaline membrane or the ARDS membrane that affects gas exchange. And this is the point in time where most patients worsen and they go on mechanical ventilation. They're not liberated from mechanical ventilation. They go on mechanical ventilation at this particular point of time. And the peak onset of symptoms is during this phase. Okay. All of the following are true regarding the lung injury prediction score in ARDS, except it has a low positive predictive value for ARDS, has a very high negative predictive value for ARDS. Threshold score is greater than or equal to 6, and aortic surgery carries the highest risk points for lung injury. So there is something called a lung injury prediction score, which helps you to rule out or rule in ARDS. So depending on that particular score, you could probably say, depending on the etiology and depending on the factors that the patient has, you can say if the patient is how likely the patient is going to have ARDS. That is called a lung injury prediction score. So which of the following is not correct in this particular regarding particular score? That is lung injury prediction score. Okay. Any answers? Okay. This is a bit tough. This is a tough one. This is a relatively newer concept. I mean, not many people teach you this. So the answer is going to be threshold score greater than or equal to 6. I'll tell you what the lip score is. See, this is the lip score. Look closely. Basically, it has a series of predisposing conditions the patient can have. So predisposing conditions and risk modifiers, and you add up the scores accordingly. So depending on the score, if the score is greater than or equal to 4, the threshold is 4, then the patient has a very high negative predictive value for having ARDS and a low positive predictive value. This particular score has a very high negative predictive value, which means if it is negative, then definitely the chance of patient having ARDS is very less. But if it is positive, doesn't mean the patient is definitely going to have ARDS. That's the idea here. So I hope you know what is an NPV and PPV. There's negative predictive value and positive predictive value. There's lip score. It basically has two sets. One is the predisposing conditions. The other one is risk modifiers. Your predisposing conditions like shock, aspiration, sepsis, pneumonia, any risk factor is going to put a patient at risk for developing ARDS. And any other condition the patient already has that is going to modify the risk accordingly, either increase the risk or decrease the risk. Accordingly, you have a set criteria and you add up, depending on the patient details, you add up the entire score. And if the score is greater than or equal to 4, the possibility of the patient having ARDS is very high, which effectively means if the score is negative, the chance of the patient having ARDS is very less. But if the patient is positive, if the score is positive, it's more than 4, it doesn't mean, if the score is less than 4, doesn't mean the patient is not going to have ARDS. In simpler terms, the negative predictive value of lung, this LIPS score is extremely high. It's almost as high as 97%. But the positive predictive value is very slow. It's only around 18% or 20%. So it has a very poor positive predictive value. Right? That's the first thing. Second thing, cutoff score is 4. And look closely, the highest point is given for aortic surgery. It's almost 3.5 points. Is what is given for aortic vascular surgeries. So that carries the highest risk. Which of the following statement is incorrect regarding mechanically ventilating a 55-year-old diabetic male with ARDS secondary to influenza pneumonia? A. Low tidal volume ventilation, 6 ml per kg of predicted body weight has a mortality benefit. B. Plateau pressure is target at less than or equal to 30 centimeters of water. Recruitment maneuvers are efficient in reducing 28-day mortality. D. Mechanical ventilation in the prone position can improve arterial oxygenation. Yeah. So a lot of bright people here. Recruitment maneuvers have definitely not shown any mortality benefit. In fact, recruitment maneuvers have shown to be having worsening mortality. So there are a few studies done. The most important study is the FARLAB study that was done. And that study, PHARLAB, FARLAB study, and a number of other studies which effectively showed that recruitment maneuvers are going to worsen your mortality. For people who do not know what recruitment maneuvers are, they effectively are maneuvers where you actually increase the pressure, sustained increase in alveolar pressure over a period of time in order to recruit or extend the alveoli to improve gas exchange. That's what recruitment maneuvers are. They were previously done, but nowadays it's not done. It's not advocated for very simple reason that there's higher risk of barotrauma and it is actually shown increased mortality in a lot of studies. So you do not do recruitment maneuvers anymore. Low tidal volume ventilation, yes, it has clearly shown mortality benefit. You always target a plateau pressure of less than 30. And mechanical prone positioning is something we'll see in detail as we move forward. So the prone position has definitely shown to improve arterial oxygenation. So the other three options are right. Recruitment maneuvers are definitely not something that you will do. So next question. Which of the following statements is true regarding the critical care management of a 43-year-old female on mechanical ventilation with severe ARDS secondary to urosepsis? A. Fluid restriction and diuretics are an important aspect of ARDS management. B. Neuromuscular blockade is harmful in patients with severe ARDS. C. Routine use of glucocorticoids in severe ARDS have never shown any outcome benefit. D. Inhaled nitric oxide is preferred over prone positioning and refractory hypoxemia. Okay, so there are a couple of A's and one C here. Right. I'll move forward. So it's pretty simple. The answer is A. I'll tell you why. I look at go option by option. I'll start from the option B and finally I'll go to option A. Neuromuscular blockade in ARDS. It's a very important concept. Okay. Any patient in severe ARDS after intubation, when they are breathing on their own, when you breathe on your own, what happens is on a ventilator, you're giving positive pressure. Patients breathing on their own is negative pressure. There's a lot of asynchrony, which means the most important injury as far as ARDS patients on a ventilator is concerned is ventilator-induced lung injury. I do not want to produce ventilator-induced lung injury in these patients. That's what we call VILI, or otherwise called PCLI in recent terms. Patient self-inflicted lung injury is what we recently call it. VILI and PCLI are something you do not want the patients to have, because when the patient breathes on top of the ventilator and the patient is having wide, deep inspirations and expirations, you know what wide shifts in their transpulmonary pressure. The transpulmonary pressure is going to keep varying between this end to that end, which effectively means the patient is going to have more biotrauma. Biotrauma is because of the wide swing in their transpulmonary pressure, the alveoli are opening and closing very fast and in erratic rates. This is going to cause a lot of shear stress to the alveoli and cause more injury and more ARDS. So for these patients, I do not want to cause this kind of injury. So I would want to keep the ventilator under my control. So this has been effectively shown in many studies. A couple of important high-profile RCTs that neuromuscular blockade actually has mortality benefit in these patients. Right? That's the first thing. Second thing is, once I paralyze the patient, that is, once I give a neuromuscular blockade, the oxygen requirement of your respiratory muscles come down. Right? Once I'm in distress, the muscles need a lot of oxygenation, a lot of blood, and a lot of oxygen. But once I paralyze the patient, my respiratory muscles can rest, which effectively means they do not need a lot of oxygen. So in a patient who's already hypoxic, if I'm going to reduce the demand of oxygen from these muscles, it's going to be utilized in other tissue perfusion. This is actually pretty much useful in these patients. So these are some of the ways in which your neuromuscular blockade has shown to improve mortality benefit in these patients. Right? That's option B. That's why it is right. Second, routine use of glucocorticoids in severe ARDS has never shown any outcome benefit. It's absolutely wrong, because it's absolutely right, because I'll tell you one thing. Previously, till 2020, we thought in ARDS, steroids might be counterproductive, because whatever studies we had till 2020 or before that, they said, no, it is not possible to these patients might not benefit from steroids, and that's what the studies showed. But there are two important studies, one in COVID, one in non-COVID. What we are talking about is non-COVID ARDS, because the patient is having urosepsis, and this ARDS is likely secondary to urosepsis, right? So in COVID ARDS, you all know we are using dexamethasone because of the recovery trial, which showed benefit in patients with moderate severe ARDS. So that is done. But in patients with non-COVID ARDS, there was a trial that was called the DEXA-ARDS trial. They used the protocol of dexamethasone, and they showed that these patients had mortality benefit, and their time to liberation from mechanical ventilation is actually quicker, without much difference in the side effects. So after that study, it has been shown that there is some use of using glucocorticoids in severe ARDS, but it's not still widely used in all patients across many centers. But still, there is some hint towards benefit in this subset of patients as far as a couple of studies. Option D, inhaled nitric oxide is preferred over prone positioning, is absolutely wrong. Prone positioning, as far as the PROSEVA, the most famous PROSEVA trial is concerned, has clearly shown that these patients have mortality. The patients who are prone actually do better. They have mortality benefit. Their oxygenation actually improves better as compared to inhaled nitric oxide. Inhaled nitric oxide has no evidence whatsoever, although it is still used as a pulmonary vasodilator, local pulmonary vasodilator, and in patients with RV dysfunction, where it could help in reducing the RV after load. It is not something that has shown any kind of mortality benefit. So if you have an option of using nitric oxide or proning, you should always choose proning. So coming to option 1, fluid restriction and diuretics are always important in ARDS, because it's shown that negative fluid balance helps to bring the patient out of ventilator. This time, the duration of mechanical ventilation and the ventilator free days is actually better with patients who are on negative fluid balance. Of course, in the initial part of the illness, when the patient is in shock or the patient is not having adequate organ perfusion, your idea would be, your goal of trial would be to definitely give the patients more fluid and improve organ perfusion. But as you move forward, you would probably want to diurese and bring the patients out of the positive fluid balance. Yes, Dr. SK, as you say, it's called a FACT trial, FACTT. That is this basically what was a 2x2, it's a bifactorial trial, whereas what they did was they divided the patients into two groups, a conservative group and a liberal group. And based on they used the pulmonary artery catheter to look at oxygenation indices and the CVO, the central venous oxygen saturations, and they gave fluids based on that. And the liberal group actually had 7 to 9 liters of positive fluid balance at the end of 1 week, while the conservative group had almost even balance. So that was the difference. So the even group was almost like 7. The conservative group was almost at even balance, while the liberal group had almost 7 to 9 liters of positive balance. So that's something that's too much. The 9 liters of fluid balance, positive balance at the end of 1 week, any patient is going to struggle to breathe. So that was kind of the difference that they showed, and they showed, although the trial did not show any. One thing I wanted to notice: the trial did not show any mortality benefit. There was no mortality benefit as far as the trial concerned, but they showed that the time to liberation from mechanical ventilation, the duration of mechanical ventilation, is actually shorter in these patients, and that's what it actually showed us, right? So which of the following is the only therapeutic intervention based on level A recommendation in the management of ARDS? A, prone position; B, ECMO; C, low total volume ventilation; D, early neuromuscular blockade. It is routine use of early neuromuscular blockade. Yeah, I think all of you have studied ARDS. So the answer is low total volume ventilation. So just look at this set of evidences. I mean, it's pretty easy. There's only one intervention that has shown grade A, a level A recommendation, that is low total volume ventilation. And there are a couple of B recommendations. That's what I told you, like, the minimized left atrial filling pressures. That is what we spoke about, negative fluid balance. That is B. And high PEEP or open lung strategy, which we always talk about, is B. Prone positioning is also grade B. The rest all have shown not much benefit. Which scenario aligns most closely with the diagnosis of ARDS for a 56-year-old male in the ICU with severe breathing difficulties? A, blood gas analysis showing an PF ratio of 430 on room air. B, chest X-ray revealing bilateral infiltration positive viral PCR for influenza A. C, 12 weeks history of worsening shortness of breath. D, transthoracic echocardiogram indicating a left ventricular EF of 25%. This is just a quick recap of whatever we've discussed so far. I mean, we have discussed so far about ARDS, about the definition and all that. So this is just a quick recap to just differentiate what is it. Yeah, it's straightforward, right? The answer is B. The patient who's having a chest X-ray revealing bilateral infiltrates definitely going to be more susceptible of ARDS. If your PF ratio is 430 on room air, you can sit at home. You don't even have to be in the ICU. 12 weeks of history of shortness of breath is not acute. There's something else going on, subacute history, so you'll have to work up for other reasons. Transthoracic echocardiogram indicating an EF of 25% would mean the patient is having heart failure and cardiogenic pulmonary edema and not non-cardiogenic pulmonary edema. So that is also not right. So it's going to be option B. A quick word, as I told you about the pathology of ARDS. Some examiners are fond of asking about 1 or 2 basic science questions in your critical care paper. This is something that potentially can appear. In the early stages of ARDS, what is the most likely histological finding? A. Hyaline membranes and alveolar infiltrates. B. Interstitial fibrosis. C. Non-caseating granulomas and giant cells. D. Organizing pneumonia. So a lot of A's. So talking about the pathology in a nutshell, the acute respiratory distress syndrome is characterized by several histological features during the 3 stages of its process, called exudative, proliferative, and fibrotic process. The earliest that we spoke about is exudative. We previously spoke about the proliferative phase, which occurs after 7 days. But the earliest that occurs between the first day to 7th day of illness is the exudative phase. It is characterized by epithelial and endothelial cell death. There is injury and cell death, which causes neutrophilic sequestration, which eventually causes a lot of inflammation and causes fibrin deposition. This fibrin deposition, endothelial dysfunction, and endothelial injury causes a lot of platelets to be mobilized and cause production of platelet-rich thrombi. Now there is inflammation, there is neutrophils, there is platelet-rich thrombi. Next thing that happens is your capillaries start leaking. Once your capillaries start leaking, there is going to be interstitial edema. That interstitial edema causes all of this now organized into one family, which causes the accumulation of alveolar exudative fluid into, this then evolves into form a dense protein-rich hyaline membrane. That's how it progresses. The first injury is going to be, because of the SIRS, there's going to be epithelial and endothelial injury, which any injury in your body is going to cause inflammation. Inflammatory mediators are usually produced by neutrophils. The neutrophils come in. Once the neutrophils come in, they cause injury, more injury by releasing more cytokines. Platelets come in. The platelets try to plug all the leaky, the endothelial injury and the leaky capillary, which in turn form a thrombus formation, activation of the cascade, the coagulation cascade there, thereby causing a lot of leaky capillaries, which cause interstitial edema and further progresses to form alveolar exudates and hyaline membranes. That is how the disease progresses. Now, a 41-year-old woman is admitted to the intensive care unit with influenza, pneumonia, and acute hypoxic respiratory failure. She is intubated for mechanical ventilatory support. Settings are assist control ventilation with an FiO2 of 0.9, that is 90% of FiO2, with a PEEP of 15, respiratory rate of 22, and a tidal volume of 5 ml per kg ideal body weight. Plateau pressure measured on the ventilator is 30 centimeters of water. Chest radiograph demonstrates bilateral infiltrates. At ABG shows a pH of 7.28. CO2 of 62 and a PF ratio of 90. So bedside echocardiography shows normal LV function. Which of the following therapies is most likely to reduce mortality in this patient? A. Inhaled nitric oxide. B. Prone positioning. C. BV ECMO. D. Tidal volume adjustment to normalize arterial pH. Okay, somebody says prone positioning. One of you say VV ECMO. Here, I would like to ask one more sub question before I go into the explanation for this particular question. So I have a lot of people giving me an answer of prone positioning. Yes. Why is option D wrong? Can I allow a pH of 7.28 in this patient with a CO2 of 62? Yeah, prone positioning is definitely something that you need to consider. Can I allow a pH of 7.28 with a CO2 of 62 in this patient? Can somebody type in or give me an answer? Okay, we might increase tidal volume at 6 ml. Okay, some people say yes. Dr. Harsh is right. This is what you call permissive hypercapnia, right? So I'll tell you, I'll talk to you about the concept. Look, as far as ARDS is concerned, what am I more worried about? I'm worried about two things. One is gas exchange, the other one is lung safety. I need to ventilate a patient in ARDS, but I need to consider they have to be ventilated safely. At the same time, they need to be ventilated for adequate gas exchange. So what am I more worried about? Am I worried about gas exchange or am I worried about safety? I'm first worried about safety. But at the same time, I need to make sure I ensure adequate gas exchange. I can ensure in ARDS during my ventilation, my goals are very simple. I will be having a separate session on mechanical ventilation of patients in ARDS, where I will be discussing about all this, how to ventilate a patient in ARDS and all these driving pressures and all these pressures. But I'll tell you one thing. As far as ARDS is concerned, my worry is about something called the driving pressure. Driving pressure is the distending pressure of your alveoli. The more the distending pressure of the alveoli are going to go in for more injury. So I want to minimize the injury and cause effective gas exchange is my concern. So what is driving pressure? Driving pressure is plateau pressure minus total PEEP. right? So if my and the target I want here is 40. In another class, we'll probably discuss about driving pressure in detail. But here, as far as I want you to know is 14 or 15 of driving pressure is what here the driving pressure here you look at very simple is your plateau pressure is 30 and peak of 15. So driving pressure is 15. So I am reasonably okay. I am within the range of but am I still happy here? No, because my FiO2 is 90% and my PF is only 90, which effectively means although I'm maintaining the patient safely, doesn't mean I'm happy with the gas exchange here. And more importantly, my PEEP is 15. With a PEEP of 15, chance of barotrauma is also high. I am having a high PEEP and my gas exchange is not adequate. But I can still allow some amount of hypercapnia in this patient because I am only going to target a pH in this patient. I'm not going to target a CO2. As long as my pH is more than 7.2 to 7.25, I'm not worried about the carbon dioxide. I'll be very happy if I drive home this particular message today. In ARDS, do not look at the CO2. Always look at the pH. If the pH is 7.2 to 7.25, I will be happy. But what are the caveats of giving permissive hypercapnia? Who are the patients where I cannot allow permissive hypercapnia? So, in patients with traumatic brain injury, I cannot allow permissive hypercapnia. I think most of your anesthesiologists here. What is the effect of carbon dioxide on ICP? Higher the carbon dioxide, there's going to be increased ICP. There's going to be cerebral vasodilatation. The cerebral vasodilatation is going to cause increased cerebral blood volume and ICP is going to rise. So, hypercapnia can be counterproductive in patients with high ICP. So, any patient with high ICP, traumatic brain injury, stroke, or anything that causes increased ICP, I cannot allow permissive hypercapnia. First. Second, pregnant patients where you are going to compromise fetal circulation, I cannot allow permissive hypercapnia. Right? So these are a few patients where I will not be able to. And patients with RV dysfunction. Patients who are having RV dysfunction, allowing hypercapnia is going to cause more pulmonary vasoconstriction, and that is going to cause worsening of the RV failure. So patients with RV failure, patients of traumatic brain injury, and or any high ICP status, and patients who are pregnant, I cannot allow permissive hypercapnia. So, but in every other patient, I can always consider allowing hypercapnia, provided my pH is between 7.2 to 7.25. Right? That's the first point I want to drive home. The second point I want to drive home here is safe ventilation at the same time effective gas exchange. This patient, although if my target is going to be a driving pressure, about which we will discuss in the next class, is 15. My gas exchange is not adequate, so I need to consider anything that is going to improve my gas exchange. I'm not worried about tidal volume adjustment here. As somebody suggested, increasing tidal volume to 6 ml per kg is going to increase my plateau pressure. It's going to increase my plateau pressure. That is going to cause increased driving pressure. Is going to cause more injury. So I don't think I don't have to increase the tidal volume just to improve my pH. Number doesn't matter here. So the only thing I would probably have to do here is improve my gas exchange by other measures, and the most effective measure that is shown to improve gas exchange and has shown mortality benefit is prone positioning. Because of alteration in blood flow and your VQ mismatch and all that, again, that's a separate class. I will do one on mechanical ventilation ARDS and all these different maneuvers. So I will discuss about driving pressures, transpulmonary pressures, EID, and proning in series in that particular class, which will probably be in the next 10 or 50 days. But yeah, that is what we will actually, this is what we will do. So this patient, I would go ahead and do a prone positioning. Right? Did it make sense? Any doubts here? We are going to come to the last question of the class. Any doubts here so far? Or anything you want, any feedback or? All right. Okay, we'll finish the last question and I'll come back to the feedbacks. Right. A 28-year-old woman, 70 kg currently, pre-pregnancy weight was 60 kg. At 35 weeks of gestation, presents with sore throat, fever, nasal congestion, cough, and dyspnea. So basically, she has some viral-like illness. On examination, she is febrile, temperature of 101, BP, she's stable but with heart rate of 128, oxygen saturation of 96% with 2 liters per minute via nasal cannula. Patient is in mild respiratory distress, lungs are clear to auscultation, and abdomen with gravid uterus and no peripheral edema. As we move to the labs, she's SARS-CoV-2 positive. Chest X-ray has shown multifocal airspace opacities, ABG 7.41, PCO2 of 27, and PO2 of 74 on 2 liters of nasal cannula. She is admitted for continuous fetal monitoring. Over the next 24 hours, she has progressively worsens, has worsening respiratory distress with a rate of 40 breaths per minute and increasing oxygen requirements. The repeat chest X-ray shows worsening bilateral Don't ask me why you did a chest X in a pregnant patient. It is definitely allowed after shielding. So repeat chest X-ray shows worsening bilateral alveolar infiltrates and ABG on 100%. Non-rebreather mask now shows pH of 7.19, PCO2 of 58, and the PO2 of 58 and the PCO2 of 136. Okay. PO2 of 136 and PCO2 of 58. These are 100%. So 100% oxygen, PO2 is only 136 and the PCO2 of 58. The patient is emergently intubated for acute hypercapnic and hypoxemic respiratory failure and placed on mechanical ventilation. What are the most appropriate ventilator settings as far as this patient is concerned? Okay. A. I would use a volume assist control mode, the tidal volume of 420 ml, the rate of 20 and an FiO2 of 100, PEEP of 8 and a peak inspiratory pressure of 32 with a plateau of 24. B. A volume assist control mode with a tidal volume of 360, rate of 18, FiO2 of 100, PEEP of 8, PAP of 30 and a plateau of 22. In the same mode, tidal volume of 480, rate of 16, FiO2 of 100, PEEP of 8, PAP of 45 and plateau of 26. For the same mode again, tidal volume of 500, rate of 18, FiO2 of 100, PEEP of 8, PAP of 40 and plateau of 31. If you want to go back to the question, the patient is 28 years with this body weight and all the settings. And this is the setting that you need to set. Tidal volume, so Dr. Hirsch says B. Tidal volume of 360, rate of 18 and FiO2 of 100, PEEP of 8, you want a PAP of 30 and plateau of 22. Good. Okay. Okay, all of you are going with B. I'm very happy about that. Okay. Why B? I had given you two body weights, right? I had given you one pre-pregnancy body weight or post-pregnancy, current pregnancy body weight. Which one would you choose? Yeah, ideal body weight. Both of them are ideal body weight. But one is 70 kgs, that is current weight. Yeah, the other one is a pre-pregnancy ideal or predicted body weight, 60 kg. Which one would you ideally choose? The 70 kg or 60 kg? So in pregnant patients, it has been clearly shown that you need to consider the pre-pregnancy body weight. Okay. Yeah. So mechanical ventilation, as far as the ARDS network study for pregnant patient goes, you always use the patient's ideal non-pregnant adjusted body weight or predicted body weight. This helps you to avoid over-dissolution of the lung and maintain the plateau pressure of less than 30. So the initial setting should be 6 ml per kg of predicted pre-pregnancy body weight, and the respiratory rate adjusted to a maternal PCO2 of 28 to 32. So you know, like because of the fetal maternal circulation, I would probably choose 20 to 32. And you already know patients in pregnant patients always have a respiratory alkalosis with a PCO2 of 20 to 32 as far as this trimester goes, as depending on the trimester, but usually it's between 28 to 32, and you probably target that. And you monitor the patient for development of intrinsic PEEP. So I'll discuss about intrinsic PEEP later. So now you go to option B, look very closely, 60 into 6 ml per kg body weight, so 60 ml. I'll start the rate of 18, then titrate up and down depending on the PCO2 and the pH, mostly depending on the pH. And here the idea is to target the pH, PCO2, not the pH, right? I told you, no permissive hypercapnia. I would probably target the PCO2. Start with an FiO2 of 100 and titrate down. PEEP of 8 and a plateau of 22, so driving pressure is 14. The same, whatever we spoke about driving pressure non-pregnant patients, also applies for pregnant patients. I am not worried about the peak inspiratory pressure very much, as long as it's within safe. Okay. So this was actually the introductory class to ARDS. I just wanted to give you a insight into what ARDS questions look like. We could do one or two more classes on ARDS. I'm planning for one definitely, which is based on these maneuvers to improve oxygenation and gas exchange in ARDS. The other class, if possible, would be the trials in ARDS. I'm not sure if that would be a very useful class for your exams, but see, one thing I'll tell you is don't look at all the trials, because you might get one question or maximum two questions in about trials. But the trials will definitely not, they're not going to ask questions directly the name of the trial. That's going to be probably one question out of all the trials done in critical care. Critical care has so many trials. So the moment you start remembering all the trials for your entrance exams, it's going to be difficult. Maybe if without your knowledge, if you're going to remember a few trials, it's okay. But don't try too much to, don't waste your brain space on remembering the trial names. Remember what the trials or what the evidence actually said. That's going to be more important. As I emphasize about recruitment maneuvers, your glucocorticoid, your tidal volume ventilation, prone, and all that. More than the name of the studies, it's what the studies told you that's more important as far as the entrance is concerned. Once you become a critical care physician, yes, these trials become your bread and butter, and you have to remember the name. You have no choice. But now, probably as you just start preparing, I think you should just remembering these classes. Remember the name of these trials, and I mean remembering the content of the trials rather than the name of the trials is what I would suggest. This class is just an introductory class. I have not gone into details of ARDS or ventilation and all that. It's going to be a separate class. So any feedbacks or anything you want me to change or anything, you can, the class will be open for next 2 or 3 or 4 minutes. You can give me some feedback, and later we can wind up. Ankur, you can allow them to unmute if they want.
Sure, sir.
If anybody of you want to unmute and tell me something, also you're most welcome. That way we can make it more interactive, and I also want some suggestions on what kind of, if these kind of classes are okay for you as we move forward. Because we are planning for 3 months. See, I'm basically in my final year of DM, so I'll probably I'm going to finish my critical care in a month. So after that, after my exams, I'll be more free, and I can, my exams are on Jan 17th. So once my exams are done, I can, I'll spend more time with you guys and have regular classes, maybe weekly 3 or 4 classes. Till then, we'll have probably weekly 1 class or something like that, or weekly 2 classes, depending on the schedule. So for now, the idea is to make sure we finish all the key topics in critical care before March 15th or March 20th maximum. So 15 days before your exams. Yeah, that's the plan. The first 3 classes are going to be free, and later on, I think that the course will start. So we'll make sure we record all these classes and put up on the app once you subscribe to them. The first 3 classes will be available free on the app. Any other feedbacks or anything you want? Would you guys want the next class on 7th or 8th? Whoever is present here. 7th is a Saturday, 8th is a Sunday. All right. So that's the plan. The class is now scheduled for 7th. It's a small change. Okay, voice could be more clear. I'll definitely work on that. Maybe was the voice not clear to everyone, or Uncle, was the voice not clear?
It was clear, sir. Maybe due to some network issues, sir.
Okay, I'm sorry. Maybe I'll probably. Okay, thank you. Okay. So what we'll probably do is on 7th, I mean the 7th, as per the schedule says respiratory failure and pneumonia, and 9th it says pulmonary embolism. But my plan is to do pulmonary embolism on 7th and pneumonia on 9th. So there could be a small change in the topic alone, but we'll have a class on 7th and 9th. So the next 2 classes will be on 7th and 9th. So we'll have the 2 trial classes, and then you guys can. Yeah. So the question bank, what I planned is we'll start with the classes, and once the classes are started, I thought I'll upload the question bank on the app, so both can go hand in hand. So I've also been stuck with my exams and these classes and the question bank, so I'm doing a lot of work right now. So please bear with me. Maybe give me some more time. I'll probably come up with the question bank once this first 3 or 4 classes are done. I'll get a hang of things and start doing it. Is that okay? So if you have any doubts or any queries, you can always personally text me, or you can put a message on the group, and we can always work out of what you want. If you have any suggestions or any classes that you would specifically want, you can always go ahead and tell me. I can always work it up. We'll have more frequent classes after Jan 19th. Till Jan 19th, we'll have that's probably once, twice a week or something like that. So we'll finish 7 to 8 classes before probably 6 or 7 classes before my exams, and we'll do more classes after that. Okay. Thank you. If there's no, any negative, negatives or anything that you would want me to improve, because I'm also just starting. So, you guys, if we correct it here, yeah, the entire course is going to be MCQ based, because I don't think teaching critical care concepts, getting classes, chapters in 2 to 3 minutes is definitely not going to help. That's going to look like a crash course, and that crash course is definitely not going to help you learn anything. What I would probably suggest is, if it's MCQ based, I can at least drive home a few key points, and those key points can actually help you go back and read those topics if you are if you have time and do it. Yeah, I think this is the better way of doing it, and I think that will also help you stay focused. Yeah, we'll do that. We'll definitely work on the MCQ based pattern, and we'll move forward as you. So stay tuned to the groups. You will have more information there about the classes, upcoming classes, and about the question bank. Thank you.